Well, Heather, thank you so much for being here. I know you're in the heart of New York City. You're a nurse here at a major hospital in New York. And I think there's some confusion for a lot of the public right now about what's really going on in Manhattan. I mean, we're seeing the numbers and the growth and the fatalities and the cases, but can you give us an insight? And first of all, thank you for your service. I know it must be very challenging working with a lot of critically ill people. How long have you been a nurse, and how different is this pandemic compared to previously caring for patients?
Sure. Thank you so much for having me on, by the way. My career in nursing is relatively new. I just started my career here in New York City this past October. So
Okay.
in March will be my 6 months of nursing. Just recently graduated last May. So previous to the middle of March, I would say our first case at my specific hospital was like March 11th. And our first case in New York City, I believe, was around March 1st, March 2nd. So previous to our first coming around, I feel like the strain on all of the hospital collectively was a lot less. And the fear going to work obviously was minimal. You know, the things that we see typically we still deal with infectious disease all the time, but something this infectious was definitely threw us all through a loop. And a lot of us didn't expect to be working directly with these patients. We expected them to be managed on certain units and kind of isolated, and now they're very much throughout the entire hospital. And all nurses are really having to be on the front lines here instead of a specific cohort of nurses.
Mm. So if I heard you correctly, and just to clarify, so the way that I foresee this, and of course I'm not a health professional, is that these patients that are COVID-19 positive, they're in the ICU or the ER, but due to the hospital bed and supplies shortage, non-elective procedures and so forth have been canceled. So are you saying that these patients are being put all throughout the hospital, and therefore everyone's exposure is much higher?
Yes, so we have multiple levels of care. So these patients are not all in ICU level of care, critical care. I work on acute medicine, which deals with, you know, your typical COPD exacerbation, your heart failure, your kidney failure, you know, liver problems, basically cellulitis, osteomyelitis, all these different medical problems where people are usually more hemodynamically stable, their blood pressure is stable, their vitals are good, they usually can talk to you and walk, maybe. So we have that level of care as well, and there are COVID patients on that level of care. So there's medicine, which is what I work on. There's step down, which is between medicine and critical care. And then there's critical care, which are intubated and ventilated patients. So my unit that I work on currently just was designated a full COVID positive unit. So all of our patients will be COVID positive, and they are stable, but we kind of watch them to see if they decompensate. And then at that point, we would need to escalate care to something like ICU.
Mm. And so stable, meaning their oxygen saturation is good, they're breathing okay, things like that. I mean, and how quickly does someone go from, in your experience, so we hear different reports, in 12 hours, someone can be totally normal and then just start crashing. How have you seen some pretty drastic shifts here?
Yes. And that's the thing that I think most surprised me is I've never seen, you know, even with our flu patients, our pneumonia, really bad pneumonia, and the elderly, they usually don't decompensate, and their oxygenation status doesn't usually decline as quickly as we've seen it decline in COVID patients. So they'll be on nasal cannula, which is kind of the most minimal way to supplement oxygen. And they'll be on 1 liter, and then all of a sudden they need 2, and then 5 liters and 6 liters of oxygen to maintain above 92%. Or if they might have a history of asthma or COPD, our goal for them may be above 89%. So they start to drop, and that's when we get concerned. We have to escalate to different types of oxygen masks, like a non-rebreather, and that's kind of our rescue oxygen. And if they continue to decline on that, we would need to call what we call a rapid response, which is when the critical care attending comes, our alert nurses come who have specialized training in emergencies, respiratory therapy comes, a whole bunch of people come to the bedside to prevent something extremely deleterious from happening. So prevent respiratory arrest is basically our goal there.
Mhm.
And then at that point, they would decide, okay, what's the change in the treatment plan? How do we better accommodate these oxygenation needs? Does this patient need to be intubated? And, on that pathway.
So for intubation, for people that don't really understand, and I don't know all the details, right? But that's, you're forcing manually some things down your throat, essentially. So do you have to undergo like a little partial anesthesia or pain meds or analgesia or something like, and you have to be pretty still, right? Or
So in my level of care, we don't deal with intubation and ventilation too much. So I'm absolutely not an expert on this. I believe that, once they are intubated, they are medically paralyzed with like fentanyl and propofol and those very, very serious medications. As far as emergent intubation goes, I am definitely not an expert on that, but those patients would not be on our floor, on our level of care at that point. They would be in critical care.
so, but basically, I mean, once you go down that route, I've heard that the longer you're on the ventilator, the chances of poor outcomes is much, much higher, right? And other co-infections and things like that.
Absolutely. And with coronavirus, we're seeing some involvement of the kidneys that can be extremely, that has a very poor prognosis if there is kidney injury involved. And I've heard the chance for extubation, which is when they take the breathing tube out. For your followers, that going back to intubation, the basics, you basically slide a tube past the epiglottis, which which separates the trachea from the esophagus. And so that tube goes down to the lungs, the airway, and the trachea, and then you're able to put forced oxygen into the airway space. And a patient might need that if they're breathing so fast, they're tachypneic because of the inflammation, which we're seeing with COVID-19 in the airway. The alveoli are unable to expand fully and get that oxygen down into the very furthest parts of the lungs. So in that case, you would need to be intubated so that we can keep you alive and keep your oxygen up so your brain can get oxygen, your vital organs can get oxygen. So going back, we are seeing lots of, multi-organ failure. And this is specific to COVID-19, which is really interesting because of this inflammatory process, which is why people are seeing we're using all these interleukin-6 inhibitors as treatments, because this mass immune attack on your body is causing all these organs to fail. And when that happens, it's very hard to treat. And so if we remove that airway, you're not able to breathe on your own, and that patient will die a natural death. So that's kind of the prognosis. And I had one patient that, we're dealing with very hard ethical issues right now. And no family member wants to hear that their dad is, with all their risk factors, they're over the age of 80, they have a history of dementia. We are not going to intubate them because the chance of them getting off the ventilator is very low. That's a very hard conversation that a lot of our brave attendings are having to have with these families right now.
Now, those individuals that require intubation, are they most likely, I mean, statistically, from the data that I've read, have a more comorbidities? So from heart disease to diabetes to, you mentioned COPD, asthma, things like that. But obviously there's outliers. Is there some healthy 20-year-olds that have needed intubation, or is it majority of which are folks with other comorbidities and things of the sort?
Yeah, so from hearsay, so not my personal experience, but I can tell you that I've heard that we've had some 20-year-olds be intubated and actually put on ECMO, which is when your blood is actually circulated outside your body too, because your heart's not working properly with no past medical history. But by far, the people that need to be ventilated have these comorbidities, or they are older, more high-risk individuals. But we're seeing everything, and I think there's so much of this that we don't know yet, and that's what's scary. Is with the flu, we kind of know what we're getting into with the flu, but with this, there might be some individualization as far as the patients that are affected and how their immune system responds. And now, you know, what pre-existing condition of it, and you know, history of immune function prior to getting this infection. That could be something that we could talk about, you know, in retrospect when this is all said and done, and we can go into that. But right now it seems to be affecting different people differently. And so I'll have an 85-year-old and they'll be telling me they hate the food and they want to go home, and they're doing fine basically. And then I have, you know, their neighbor is another 80-year-old, and they might be the same BMI, etc. And this person's going to die. So we really don't, you know, we don't really know how this affects certain people, and that's what's scary. And that's why I think that's why this is spreading so fast and why it's getting so bad. And, you know, because we just don't know how it affects certain people.
Yeah. And that uncertainty is really, it kind of paralyzes the human mind, because we really don't like uncertainty and everything like that. But I think that's pretty fascinating. And I've been diving a little bit into the studies based upon, again, clinical case histories from Wuhan, looking at neutrophil to lymphocyte ratios and other, you know, CD8 T helper cells and things like that. But you bring up a really interesting point, is the potential genetics and other immunological biomarkers or susceptibility, and which may predispose people to have the cytokine storm, which from the cellular biology and the mechanism, the immunopathology that I understand, it seems like that's really kind of the critical thing that differentiates, you know, yeah, you have a fever and you have the symptoms, from severe disease state, you require intubation. And so it seems that the immune system, from what I've read, and tell me if you have read some of this where doctors are talking about this, that this virus is so good at penetrating inside your cells through this receptor, the ACE2 receptor, that once it starts replicating, the immune system essentially just freaks out and says, okay, we're going to throw the kitchen sink at this thing. And there's a lot of collateral damage. And you mentioned the alveolar tissue in the lungs and then potentially the heart. And so, yeah, you're like, well, what's differentiating someone like you mentioned these two different 80-year-olds, right? The one that just wants to get out of here and eat good food at home, like what is it about their immune system that's able to kind of pull the brakes back on that cytokine storm? And so along those lines, do you think there's data being collected and gathered? I mean, it's interesting, you know, because we're just now in April getting a lot of reports from Wuhan. I haven't yet seen a lot of published stuff from Italy, but I'm so curious to know, like, their vaccination status, like, you know, do they have autoimmune disease? Like, we just hear did or didn't have comorbidities. I mean, how is that data being collected, or do you know?
I think when this, you know, like I said, when this is all said and done in retrospect, when we're looking back, and hopefully, you know, during the development of this, however long it goes on, that we can start to implement some of our findings. But I know that we are obviously fully consented patients, collecting their blood, their plasma specifically, looking at their immune function, looking at these things like ferritin, CRP, because these are all markers of the cytokine storm, and trending those things, and trending their fever curve, and all of these, you know, parts of their history. And I can only hope that we're talking about their immunization status, or other, you know, parts of, you know, their genetic variants. And I think what's interesting is I've seen a lot of, like, this has been affecting people of every type of culture and ethnicity and background.
Mm-hmm.
And I think that's like the most interesting part to me. Is I'm not sure whether it's that I'm in New York City, but I feel like everyone I've taken care of has been a completely different ethnicity. So we've taken care of, you know, we have a large Orthodox Jewish population here, so they've been affected, just like in the measles outbreak situation here. I've taken care of, you know, people from Latin America, people, you know, that are Polish, Russian, just, you know, of Asian descent, everything. So it's really, really interesting to see that this is not discriminating against one certain person, and also socioeconomic status too. You know, although my assumptions are my personal assumptions, but you know, that's also been a factor that I was considering, as like, maybe this is a public health concern too, with access to care and access to resources. But I really feel like by the time we caught up to it here in New York City, it was already being community spread quite a bit. Absolutely.
I had a question about that, and I didn't want to bring it up unless you brought it up, but I was looking at, so the New York State of Public Health is sharing a lot of data on fatalities and everything like that, and they break it out by bureau or by borough, sorry. So you see Queens, Brooklyn, the Bronx, and then compared to Manhattan, at least the last time I checked, which was 2 days ago, had by far the lowest number of deaths. But I was also thinking, well, how many people live in Manhattan compared, like a lot of people commute out of the city. So I was kind of curious on that socioeconomic,
Yeah.
different. Yeah.
That's absolutely a good point. And I actually was able to look at some data that we've collected and gathered from my specific hospital today. And it looks like one thing that I can say from experience is that we get a lot of patients from those other boroughs here into Manhattan, because the level of care outside of Manhattan is not as acute or not as critical as we have here. So we are affiliated with multiple hospitals all over New York City, and some that are outside of Manhattan, those patients get sent to our hospital. So our numbers may look variable because we are treating patients that are, from Brooklyn or from Queens. So it's, as far as a recovery, I think the numbers won't start to make sense until we're looking at this from like a really huge, like, bird's eye view. And like, this is relatively the beginning for us. And we're on the front of receiving this after, like, I believe Washington and California, but the rate of the cases is still going up, which is, kind of disappointing to see with how much labor is going into this, that we're still, we haven't flattened the curve yet here.
Yeah. I mean, so when you go out, so you live in Manhattan, like, yeah. So obviously like the food scene there is totally shut down. I guess you have Whole Foods and a few grocery stands. Is that pretty much it?
Yeah. So we have Whole Foods, Trader Joe's, basically just grocery stores are open right now. Everything else is closed. Like Starbucks is closed, those types of things. And then there are some local places that everything is being done through, like Uber Eats or DoorDash. So you can still order food from like quite a few places, but as far as going anywhere and sitting down is non-existent.
But with that many people, and most people eat out all the time for most of their meals, like it must really change the dynamics of the city.
Yeah.
Yeah.
And I kind of smile when you say that, because I think that has been a positive thing. Is I feel like people are, we live in a 300 square foot apartment. Like, we live in one room, everything is in one room. There's nowhere to do a home workout in here. Like, you have to go outside. So it's forcing, even though, everyone is staying home, we're still allowed to go outside to exercise if you're like keeping distance. And that's what I've seen, is like people are trying to go outside and exercise. And it's kind of just like a beautiful thing that like people are going outside again, and being in the sun. So I think it is really, and then I think people have a much more conservative mindset with money. Like, now we see how like fragile life is and resources are, and like how we need to be careful with money. So I don't think people are spending as frivolously anymore. At least I know I'm not. So I think those are, two good things to come from this kind of slap in the face of everything we thought we knew about medicine and how we can control medicine so easily.
Totally. Yeah. I mean, it's going to really change the landscape of the world, when things get turned back online and so forth. I mean, when I go to New York, I love hopping in the subway and everything like that, but it's everyone's so germophobic now. It's going to like, even I'm like the least germophobic person ever. We let chickens come in our house. Right. But I'm like finding myself like not touching things. I'm like, Mike, oh my God, like I get it. Cause I don't want to transmit it to someone else. I'm not necessarily worried about, not that I invite the disease, but I'm yeah. So it'll be interesting to see how these cities adapt and everything along those lines. But are you saying like Central Park is more busy, for example, than it normally is because people are out and about?
So I don't live super close in New York City terms to Central Park, but I've heard people saying that people are flocking to the park.
Wow.
So I hope that they're keeping their distance, and I hope it's healthier people going out. But the reality is that we can be carriers without having symptoms.
Right.
And that is something personally that I'm concerned about, since I've had so much exposure. You never know when you're going to pop a fever one of these days. So, and I think that's kind of the collective mentality that us healthcare workers have in this weird, eerie season, is kind of just like waiting. Like, you almost feel like a sitting duck. Like people are, getting coronavirus left and right. And that includes us. So we are concerned with like what we're doing outside of being at home. But as far as taking the subway, there's still people taking the subway, like New Yorkers, like, you know, there are a lot of essential workers here, and like we don't realize that, but you know, there's tons of postal service is still very active. People that need to, you know, drive buses, go and drive ferry or pilot ferries or whatever. So, you know, that's one of the problems I think that we have specifically to flattening the curve here is that our way of life is so interconnected. And it's so like we are literally sitting on top of each other in the subway and the bus. And to see that diminish is going to take a while. So, yeah.
It's going to be tough. Yeah, it's going to be very challenging. So a final question here. You mentioned something about taking care of yourself, and I find that very interesting, and I want to elaborate that more because I've had so many people direct message me on Instagram saying, hey, I'm a nurse, or hey, I'm a doctor. Here's our break room, and it's Krispy Kremes, and it's soda, and it's donuts, and it's, you know, and I don't want to undermine the companies that are helping or trying to help health professionals by giving gifts and things like that. Krispy Kremes was one. Chick-fil-A gave a bunch of food out here in the West Coast. So, but that being said, like this is a stressful time. Like people probably aren't getting the right amount of sleep. So food decisions kind of, you know, willpower gets diminished. So we make, you know, more, we don't eat like we probably should be doing. So I know, you know, based upon your Instagram and things like that, like you're totally on it. Are you seeing people make more conscious decisions to like boost their immune system and get good sleep, or, you know, eat better compared to normal?
I think people are trying. I think people are trying to be more cognizant of it. But I think without the education, the awareness of, especially in Western medicine, like there's tons of people that will tout that, you know, doing X, Y, and Z will do nothing to help your immune system. And like that is still very much alive and well in the Western medicine, the, you know, academic world of medicine. So unfortunately, I think that stigma like towards like holistic health runs very deep. But I think there's a lot of stress eaters right now, and that I mean, it's definitely with the company sending us things and being so generous. I think people are still partaking in that. But whether, you know, they're taking an extra vitamin C supplement at home or a multivitamin, I definitely think that is the case. I mean, when you go to Target or anything here, you know, all the multivitamins, everything is completely out of stock, so you can't get Tylenol anywhere here.
Wow.
Yeah. So
Toilet paper, Tylenol, man, what's going on?
no, it's really tragic. I'm like, well, at least this one person with all the toilet paper in the whole world is going to be set for the rest of their life.
I know, that's so crazy. Well, Heather, thanks for your service. Thanks for coming on the show. And you're also studying for the MCAT. So how's that going?
Oh my gosh, that's been what a twist in the whole course of things. I just feel like I did not expect how much coronavirus would affect me mentally and emotionally, and I think the rest of us. It's only every day that we're getting, you know, messages from administrators. Oh, you've been exposed to someone that's been positive. You know, continue to take your temperature. You know, all these changes in protocol with PPE and procedures, and it's, you know, I didn't realize how much emotionally it would be, especially with these ethical decisions we're having to make. So it's been hard, but I know that there's a light at the end of the tunnel, and that, you know, hopefully it works out, and just trying to take it day by day and continue to sow those seeds and work hard and hope that pays off, and hope that my story, you know, being here with coronavirus and taking care of these patients, and hopefully it impacts some sort of, you know, part in this process. So.
Oh, for sure. Yeah. I took the MCAT back in 2009. I know it's hard you really have to have like uninterrupted blocks of study, or else it becomes challenging because there's so much material.
Well, I'm learning like glycolysis right now, and I'm like, okay, this needs to be the most focused study session I've ever done. So, but it's okay. We're going to get through this. I think we need to work as a team. I think, you know, politically we need to work as a team. And the good thing is that healthcare workers are very good at role modeling that. And I love to see that, you know, we're shopping for our neighbors, and we're thinking collectively and globally, and, you know, how we can do better by other people. And I hope that goes beyond this, and I'm hopeful for that.
Totally. I feel like just random conversations I have in the streets or at a grocery store, people are taking that extra time. Like there's not this impetus to like, hey, I got to go to do the next thing. Like people are slowing down. So yeah, I mean, maybe, again, I feel for anyone that's personally affected by this or who loses a loved one, but I think, we have to look at the potential upside and the lessons from this, which, yeah. So thanks for sharing your experience. Thanks for, helping these sick people, and good luck on the MCAT. And if folks want to connect with you, I know you're doing a lot of videos on Instagram as well.
Right. All right.
It's naturally underscore
Heather.
Heather, naturally underscore Heather. Okay, cool. All right. I'll put that in the show notes. Have an awesome day, Heather. Thanks for coming on.
Thank you.
Cool.
Awesome.
All right.
I really appreciated that conversation. It was good.
Yeah. Yeah. Hopefully it'll just give people some insights. I mean, it's really hard to get perspective, right? I mean, I think a few practitioners and stuff are doing more videos, but all we see is the doom and gloom on the news. So it's good to hear some.
Yeah. It's terrible on the news, but
right.
It's also, I also have a morgue like outside right down the street. So it's serious, but
yeah. All right, Heather. Have a great day. Thanks for coming on.
Bye.
Talk to you soon.